Hello, Oakland County Medical Control Authority, EMS providers. My name's John Toit. I am the EMS System Manager for Oakland County Medical Control Authority. I'd like to welcome you to the 2024 Protocol Implementation Education. The new 2024 protocols will be implemented on February 1st, 2024. Today, to help us with Section 1, is Captain Kevin Snell of the Oxford Fire Department. He is the EMS coordinator and has been a protocol committee member for the 3-year review process. Starting with Protocol 1-1, the first of 161 protocols, general pre-hospital care. Captain Snell, tell us all about it.
Hey, good day, John. Thanks for having me here today. I'm very happy and pleased to help the county with this training on some protocols we worked a long time on. Looking at Protocol 1-1, our general pre-hospital care, as we see here in 1A, referred to the MyMedic cards, we're going to see this a lot in all the new protocols. It's something we really worked on to access and reference that using the MyMedic cards in the event of emergencies, the way we want to go for a lot of our pediatric calls. 2, we see assess scene safety and use appropriate PPE. This goes back to day one of EMT and medic and MFR class of even BLS. Stand there, hands up, scene safety, BSI. So this was added in the general pre-hospital more as a reference here for us to do that. Number 3, we see trauma, the general trauma and protocol. So this is just a reference, as we see the reference numbers as well, 2.2 will really help the providers be able to thumb to that protocol in the event of an emergency. This was something that we spent a lot of time working on, making sure that when you put in there, see general trauma, and everyone was looking for that search bar or a better way to find something in the heat of the moment. We wanted to make it easier for the boots on the ground. Adding the reference number 2.2 to help the providers find that protocol was important. You can see that in 3. Number 4, the patient exhibiting signs of a life-threatening injury or illness should be required to move on their own. We've seen a lot of patients that are being asked to walk to a cot or to walk outside to the ambulance. This is something as pre-hospital providers, we just need to be more aware that these patients with life-threatening injuries or illnesses, or with illnesses of an unknown etiology of what's going on, we really need to just move them. We got to pick them up. We got to carry them. We got to do the best we can. We're there to be the public servants to help them. Number 5, refer to 3.7 or 4.9 is crashing arrest treatment. That's going to be a brand new protocol. We'll get into that much later, but this is just a reference to go there in the event of that during our survey. Number 6, complete a primary survey. This is something also goes back to day one of school. We all do primary surveys during our assessment, just putting that in there for us to do that. Down here at 17, use capnography. It used to say consider capnography. Now we really need to start using capnography on all serious patients. You're going to put the capnography on it. It's no longer consider, it's use it. So really, a lot of common sense changes have happened with this. A lot of changes that we learned in paramedic school or EMT school or MFR school that just made it onto this protocol to make it make a little more sense. Absolutely, John. Something that we find that over time, when the providers are out in the field and they got a lot going on in their head, they're trying to figure out a lot of things. Sometimes putting some of the common sense into the protocols as a general reminder in high stress situations is hopefully going to be helpful. The next protocol is abdominal pain, protocol 1.2. Kevin, what do you see? Yeah, we look down at number 8 and it says consider a 12 lead. Once again, this is kind of a common sense reminder that if we have somebody with abdominal pain, consider doing a 12 lead. If we rule out a STEMI or maybe we find a STEMI, this is an absolute warning sign, especially for women who have abdominal pain or back pain, that they could be experiencing a myocardial infarction. And we should be doing a 12 lead to determine that. The next protocol is the nausea and vomiting protocol, protocol 1.3. Yeah, nausea and vomiting. Here we look at some changes. Consider the underlying causes of the nausea and vomiting. So this was something that was important to the protocol committee. We talked about, we have someone with nausea and vomiting, first thought was give them Zofran. But really, if we dig into the assessment of this, there are some underlying causes that we need to be aware of. This could be secondary to an underlying problem. And if we're treating the symptoms and not the root cause, we're missing something here. So do a stroke assessment, check for trauma, do a 12 lead again here if we consider a cardiac. And diabetes is obviously really early onset, especially in children who have vomiting, or people that are hyperglycemic might be vomiting. Their sugar's gonna be really high. So we'll talk about that a little bit later with the diabetic protocol. Pediatric patients, once again, it's gonna reference the MyMedic cards, as we will in all of them. Number 4, this one made me giggle a little bit when I first saw it as well. Isopropyl alcohol. The new protocol here, we want to consider opening up a alcohol prep and letting our patient inhale the vapors 3 times every 15 minutes. Looking at the National Institute of Health, they did some studies on this, and it was actually found that it was an improved time for treatment, and it did save some additional costs. So it was just a simple, easy, give it a try, see what it does, see if it helps, and if it helps, cool. If not, then move on to giving some Zofran. Looking at number 5, we can see that the weight has changed. The weight used to be 40 kilograms. Now the weight is down to 30 kilograms. Contraindications, patients with PKU, just keep an eye out and asking our history and to determine if they are able to have this or not.
And Kevin, I think they got rid of a couple contraindications.
Yes, we did the hypersensitivity and prolonged QT.
Again, you have that reference to the MyMedic cards. Protocol 1 for syncope.
Syncope. In line 3, once again, we have a MyMedic reference. Going down to 5, this is a new protocol that we're going to be discussing later in section 7, the blood glucose testing. So this is going to be a reference of where we can find that. So 7.21 is going to be the reference for that new procedure. When we get down to 6, added alter mental status, check for a stroke. So with the 2023 EQIP training, we spent a lot of time on stroke assessments and fast CD scores. Just something to think about here. If somebody has a syncopal episode, we want to rule that out. We want to determine if there's any sort of stroke present that caused that syncopal episode. Looking down at number 9, we added a treatment for hypotensive patients. This was another one of those common sense paramedic things that if somebody has low blood pressure, we should be definitely starting an IV and giving a fluid bolus to these patients.
The next protocol is the shock protocol. This one changed a little bit. There's a lot of references now to a lot of different protocols in here. Many of them are shock protocols that we had before, but there's a new one, hemorrhagic shock. Kevin, what do you think about this protocol?
Shock here. The one thing I know we spend a lot of time talking about in protocols is I know there's thousands of providers in this county, and to get every single provider to think the same way when you're on a call is very difficult. So we have to try to consider when somebody's on a call, which protocol their brain is going to take them to. So in this shock protocol, we did put a lot of references that'll help somebody consider maybe some causes of that shock, and it'll take them to another shock protocol to help them figure out that treatment as well. Line 3, we see pediatric patients for MyMedic. Once again, that's the same as we've seen in all the protocols. Section 4, we have a new reference to another new protocol. This one came from the state. This is the BCON procedure protocols. Down in 12, there was a reference added for head injury protocol and specific vital signs, along with a reminder not to hyperventilate our patients. 13, we added a treatment for hypotensive patients. So this was very similar to the syncope protocol. If we come across somebody with low blood pressure, make sure we're treating that. And then at the end of shock, we're going to see that TXA was removed from this protocol. It had a reference in the old protocol to refer to the TXA in the medication section. Now that was moved to the hemorrhagic shock, which it was 2.14. So that'll be discussed later in section 2.
So the next protocol is anaphylaxis and allergic reaction. That's protocol 1.6. What's new here?
Yeah, looking at the anaphylaxis protocol, we see pediatric patients utilize the MyMedic cards. Make sure, once again, this is just a reference for you to remember to go to MyMedic when possible. And when we get to A.C, ensure ALS response. So anyone who is not an ALS rig, make sure that's something we're considering, getting that ALS truck on the road and called and ready for some sort of an intercept or on scene. A.D, we're just determining here between an allergy or anaphylaxis. So we want to make sure that we can understand the differences in the symptoms and determining if epinephrine was imperative or not at this point.
So one of the things I noticed about this protocol is it's longer. But when I reviewed it, I didn't find very many, if any, treatment differences. It's longer, but we're really treating the patient the same. So keep that in mind as you go through this protocol.
Yeah, that's right, John. Thanks.
So protocol 1-7, adrenal crisis, doesn't happen very often, but when it does, we need to know how to treat it.
So looking at the adrenal crisis, here we see number 2, the pediatric patients. Once again, it's just a reference to the mimetic cards. When we get down to number 3 here, this was something that was added in. Most of these adrenal crisis patients are very well versed in their illness, and they're very much aware of their treatment and what they need to do. There's a reference here that if the patient doesn't have their own hydrocortisone, meaning their own medication is the primary in this case, we want to help them take their own medication. But if they do not have it with them, then we're going to consider administering prednisone.
So then we go from a protocol we don't use very often to a protocol we use frequently, the behavioral health emergencies protocol.
That is true, John. Looking at the behavioral health emergencies, once again, number 3, this is added in some common sense. Respect the dignity of the patient. These can be some difficult calls for providers, some difficult calls for the patients as well, but respecting the dignity of the patient is going to go a long way in our care. Number 5, added some direction on when to transport. As you can see here, you can read this language, just trying to determine who needs to go to the hospital and who doesn't.
As a reminder with this protocol, you're supposed to be transporting to the closest facility for all of your psychological health patients. So the next protocol is protocol 1.9, opioid overdose treatment and prevention.
This protocol is going to replace our previous protocol of 9.9, which was our opioid overdose naloxone administration protocol. It was in the medication section. As we're aware, that is going to the reference section, so we needed to create a protocol on this. Treatment does not change, but there is a reference to the naloxone leave behind kits in here as well.
And if you want more information on the naloxone leave behind kits, that'll be in section 9. Protocol 1.10, foreign body airway obstruction.
Yeah, John. So this is the new specific protocol, but it's the same language that we had in our previous protocol 7.9, which was the emergency airway. We took it out of the emergency airway and we created our own protocol, foreign body airway obstruction. When we're out on one of those scenes and we're dealing with a foreign body, we're going to go to the protocol 1.10.
Captain Snell, diabetic emergencies. This was one that we wanted in here so that we were able to treat hyperglycemia. What do you think about this protocol? This one's a new one.
You know what, John? I absolutely love this protocol. I have a daughter who is 16 years old. She was diagnosed with diabetes at age 5. I'm very, very familiar with diabetic calls, and I'm very familiar with the treatment. This one kind of close to home for me, and I want to make sure that we're giving our paramedics ample training and knowledge on what to do for those diabetic patients, because it could be my daughter someday. So looking at the diabetic protocol, this is a brand new protocol. We definitely want to make sure that everyone's taking time to review. We're all very familiar with administering dextrose to low blood sugar, but one of the big changes we wanted to hit on here was high blood sugars. When we're dealing with hyperglycemia, we picked a number that was 250. We worked with a physicians group on that. And if we have a patient with a blood glucose higher than 250, which once again could have been a symptom we found from nausea and vomiting, we should be treating that. We've learned a long time ago in paramedic class that the solution to pollution was dilution. And when somebody has a hyperglycemic episode going on here, they can easily end up in DKA very quickly. We definitely should be starting an IV. We should be giving a fluid bolus to these patients and getting them to an appropriate facility for care. It's very common, John, for these hyperglycemic patients to end up in the ICU with DKA. In the hospital or pre-hospital field, we should definitely be treating this aggressively to make sure that we can get that sugar decreased as soon as possible.
And for pediatric patients with a blood sugar above 250, contact medical control so that you can get advice on what you should be doing for that particular patient. Thanks, Kevin. I really appreciated your insight on that.
Yeah, thanks, John. Thanks for letting me speak on that one.
Protocol 1.101, citizen assist, lift assist.
Yeah, John. So on this protocol, this is something that we've seen in the last protocol change. There's no change on this at all. Just remember when we're going out on these runs that we should be doing an assessment on somebody and filling out an EPCR on them.
Well, Kevin, thanks for joining. Kevin, we're going to see you back at section 5.
Sounds good, sir. Thank you for your time.
Oakland County EMS providers, thank you for joining us for section 1. We'll see you in section 2.